go ahead and get started then. Well, thank you very much, everybody, for coming out tonight. My name is Greg Woods. I am the program coordinator for the Alzheimer's disease and related dementias program at Iowa HHS. If you're not familiar, Iowa HHS used to be the Iowa Department of Public Health. So we are still the same people, but with a slightly different name, changed about a year and a half ago. For me in particular, I've been in this role for about 4.5 years now. And prior to that, I was a one-person office over in Fort Dodge, where I worked for the Alzheimer's Association, which is a nationwide nonprofit. I'll talk about them a little bit later. And I covered about 18 to 20 counties across north central Iowa, doing everything from support groups, care consultations, education programs, whatever they needed. As a little background before me on that, I'm originally from here in Iowa. I'm originally from Newton, and went to school at Drake in Des Moines, and then went over to the University of Iowa to do my graduate work. So that's what got me into this field in general. And this particular program, I travel around and I give this to libraries of all shapes and sizes, all around the state. So what I'd like us to do as we get into this, we have to put this up here so that we are funded by the CDC. We'll talk about the, let's see if we've got the laser pointer here. We'll talk about the BOLD Infrastructure Act a little bit later. That's what created our program, and that's what we operate under. But we'll get to that. In general, I have a few things that I'd like us to talk about, but the overarching theme that I would like you to get, if you get nothing else from this, is please be willing to talk about this subject. That is going to do a world of difference because, as you may know, there is quite a stigma surrounding Alzheimer's disease, dementia, aging, brain health. And if people don't talk about those things and they don't hear others talk about them, all of the stuff that we are doing and that our partners are doing, it's not going to matter too much because people aren't listening for it. If we can normalize the conversation, it's going to make a big, big difference. So hopefully I will convince you of that by the end of this. I'm going to leave it up to you, but hopefully that's something you get out of it. Now in terms of specific objectives, first off we'll start with what is dementia and what is Alzheimer's disease? Are they the same? Are they different? What do we know about it? Where did our understanding come from? Where is it now? And hopefully, where is it going? How do we get it? What can affect risk? What things can tip the scales? And hopefully, lower our risk, things that we can control. How widespread is this? What is the scope of Alzheimer's, not just here in Iowa, but nationwide? We talk about people affected by this disease, and it's not just those who are diagnosed. The caregivers have a huge burden placed on them. They are a really key part of this puzzle. So I'm going to talk a little bit about not just what they go through, but resources, hopefully, to help them. And then finally, this is not the peppiest subject. I get it. There's going to be some doom and gloom. There's going to be some less than ideal numbers and things over the course of this. But hopefully I'll sprinkle in a little positivity, showing that we're heading in the right direction. And I'd like to end this program with, is there a reason to hope? Is there something that is either on the horizon or here right now that is changing the game as it relates to Alzheimer's and dementia? All right, we'll get things started with a little bit of level setting. Science hasn't always done the best job of differentiating between the usage of these terms, Alzheimer's and dementia. A lot of times you'll hear them used interchangeably, but that's not technically correct. I like to think of dementia as a big umbrella term. It's a category of diseases. And specifically, they are diseases that affect how the brain thinks. To be severe enough to be a dementia, one of the key elements is it has to interfere with daily life. This is not a once-in-a-blue moon bit of forgetfulness. It's not that frustration of, oh, I'm just not as sharp as I used to be. Dementias affect a person in profound ways every single day. And that's almost a diagnostic criteria. A lot of people go to memory as being tied in with dementia, but the brain controls far more than just memory. So for a disease that affects how the brain thinks, yeah, memory is going to be affected, but other things will as well. How we think, our reasoning, our judgment, our social skills, our ability to do daily life, even the ability for our body to keep itself alive. Parts of our brain control that. And dementias can affect all of those. Also crucially, many dementias tend to be progressive, which means they get worse over time. I like to think of it like a downward slope. And you'll hear me talk about that a few times over the course of this program because there's several reasons why we need to pay attention to that slope. For progressive disease, the earlier we can get in on treating it or detecting it, the better, rather than when somebody is farther down that slope, when it's progressed more. So let's go under that umbrella. That's where we find Alzheimer's disease. Alzheimer's is the most common form of dementia. It's not the only form, but it is the most common. So what sets it apart from other types? I like to put these cross sections up here of the brain. Brain anatomy 101 here. Imagine the brain is looking directly out, and I've gone side to side, whack. You're seeing two cross sections of brains. The one on the left, that is a healthy, happy brain. It is nice and round, it's supple, you can see those wrinkles are nice and squished together. You've got these really delicate fan structures, that's where all the neuronal bodies are heading in the same direction, that looks good. I can vouch for that brain, it looks good. The one on the right, however, that is a brain that's affected by Alzheimer's disease. In this case, it's a bit progressed into Alzheimer's. And one of the first things you probably notice is it's small. There is less brain there. Those squished wrinkles have now opened up into chasms as the brain shrinks inward, and then these fluid-filled spaces inside try to poof outward to counteract the shrinkage inward. You lose the definition on those fan structures, and then crucially down here you see these two big gaps, these two big holes that weren't really present over here. It's no coincidence that these two areas are where our memories are held. It's an area known as the hippocampus. I'm not going to quiz you on etymology here just because it looks like a seahorse. But the hippocampus is where our memories are held, and it tends to be the very first place that we see affected by Alzheimer's disease. But mentioning the progression, you can see this whole brain's affected. It's not just memory at this stage. The whole thing looks different. So I mentioned that Alzheimer's is the most common form of dementia. It's not the only one. Every case of Alzheimer's is dementia, but not every case of dementia is necessarily Alzheimer's. There's frontotemporal, Lewy body, Pick's disease, vascular dementia, pseudodementias, there's Parkinsonian dementias, there's all kinds of things in that category under that umbrella of dementia. You'll hear some people use dementia as a diagnosis, but hopefully now you know, oh no, it's just a category. We need to go a little deeper and figure out what type. Alzheimer's is one of the progressive dementias, and while it does destroy memory, usually it's the short-term memory first. Obviously, other parts of the brain are going to be affected as well. One of the crucial parts of this change is that scientists now believe that this can happen, or start to happen, before any symptoms show up. In some cases, 20 years before any symptoms show up, there could be detectable brain changes physically. That may seem disconcerting, but at the same time, that's a huge window of opportunity for research. If we could step in someday and stop the disease in its tracks during that 20 years, then that person never has any symptoms. We've basically prevented the dementia from ever showing up, from manifesting. We're not quite to that point where we can stop the disease altogether, but I'll talk about where we are with that toward the end here. So that's a little bit of what the disease is. If we go back in our understanding, let's go back in history. And I think it's helpful to start with what used to be considered elderly. It's not a term that we like to use all that much nowadays, but you don't have to go back very far, and you've probably heard the terms hardening of the arteries, senility. People just kind of accepted that that's what happens when you get old. If you go back another generation before that, this was also accepted. Well, that's just what happens, but then grandma's probably going to have to go off to the sanitarium, and that's just a part of what happens when you reach a certain age. Some of that began to change with this fellow. Any guesses on who this is? He's not a president. I get that a lot. I'll say I'm not trying to trick you either.
Carl Jung?
What's that?
Carl Jung?
No, but you're in a similar time period, I believe. This is Dr. Alois Alzheimer. He was a German physician in the late 1800s and early 1900s, during that time period when elderly meant you get to a certain point, you lose your faculties, you lose your memory, you start to get paranoid, we're going to have to ship you off somewhere. He saw a patient in 1906 by the name of August Dieter who fit that bill exactly. Exactly what we think of today as Alzheimer's disease. Except she wasn't old. She was in her 40s. And to Dr. Alzheimer, he thought, how can that be? If this is something that happens as we age, she's got it, but she hasn't aged yet. Well, she actually died within a very short time of seeing Dr. Alzheimer. So he was able to get microscope slides with some of her brain tissue on it. He looked at them under a microscope, he and his team. And what they found back in 1906 is still some of what we look for in diagnosing this disease to this day. If you've ever read any Alzheimer's literature, you've heard the terms plaques and tangles. Plaques and tangles. He saw them all the way back then, and he recognized, could this be something that is a disease? These plaques and tangles shouldn't be there. Maybe it's not aging. Now, unfortunately, that's kind of where the research stayed to a degree, because we didn't have good ways to image the brain back then. We didn't have PET scans, we didn't have MRIs. X-rays don't do too much for this sort of thing, and taking microscope slides probably not the best for a living patient. So there's only so much that you could get from that. But they studied it for quite some time. He didn't actually want it called Alzheimer's disease, by the way. He said, I've got a really great team, we should call it something else, but popular opinion won. Now what he saw back then looks the same, basically, as what we see today. So this is an illustration of brain cells floating in space. The brain is mostly made up of brain cells, and these neurons are specifically how our thoughts move through the brain. And there's a couple that look really good in here. One of them is this guy right up here. Another one is this one right down here. I like to think of them like upside down trees. You've got a trunk, and then you've got roots, and then on the other end of the trunk, you've got branches sticking out. Same thing up here. Trunk, roots, trunk, branches. And all of those roots and branches are almost tangled with all the other roots and branches. And that's how thoughts move through the brain. They go from brain cell to brain cell to brain cell to brain cell, kind of like switchboards to get to the opposite coast years ago for phone calls. But Dr. Alzheimer noticed that in the middle of some of these groupings of brain cells, you'd see these big, ugly blobs, stopping those connections, breaking up those roots and branches. That's what he called a plaque. He also saw that some brain cells did not look very happy. Some of them were full of black tangled masses, and it would cause the brain cells to shrivel up and lose all of their roots and branches. The tangles inside were what he originally called tangles. Well, now we know a bit more about those. We know that each one of those is made from a different type of protein. Now, it's not like the protein that we eat meat-wise. These are cellular structural proteins. So amyloid makes up the plaques, and tau makes up the tangles. They may think, okay, great, we've identified what they are, let's get rid of them. If they're bad, let's get rid of them. Only problem with that is that we all have amyloid and tau in our healthy brains right now. They have a function, they are useful. But at some point in this disease, something goes wrong and they start misbehaving. Rather than doing what they're supposed to do, they start clumping together in between the brain cells or inside of them. And what this all leads to is the brain cells shrink, they shrivel, and they die. That's why that Alzheimer's brain on the cross-section was smaller than the healthy brain. You're literally losing the bricks that make the house. So that is where our understanding was identifying this as a disease. Now, of course, that also, on the flip side, gives us a bit of understanding into what is considered normal aging. I think we all have this image in our head of something that relates to aging, when a person looks old. Maybe it's gray hairs or wrinkles or achy joints, whatever it might be. People just imagine this as being what aging looks like, but almost nobody includes the brain in that mental picture. But the brain is just as much a part of our body as any of those things that I named. So it will change as it ages. Now, on the positive side, you should think that as we get older, you should see an increase in wisdom and expertise and worldly knowledge and street smarts and all this stuff. But on
Kids don't agree.
yeah, well, yeah. It's not always how it works out. But for the most part, you do see that, but you also see it slows down. The brain takes an extra beat to think up a name, or a location, or a word. That's normal aging. That little bit of forgetfulness here and there, normal aging. Going, hold on, is it Tuesday? Is it Wednesday? Or what, 16th, 15th? Totally normal. Forgetting where you set your keys. Frustrating, but normal. The difference would be if you found your keys and you did not know what they are for. What do these do? That would be a red flag. Doesn't necessarily mean Alzheimer's, but that would be a bit of forgetfulness that goes beyond normal aging. Driving across town, you lived here all your life, and you start getting lost. You find yourself, oh, I don't know where I am. That's a bit beyond normal aging. Going to your job where you've worked for 20, 30 years, you sit down at your desk, and you go, I don't know what the first thing is I'm supposed to do. How do I turn on my computer? What's my daily routine here? Those sorts of things should be wake-up calls to get stuff checked out. That goes beyond normal aging. But a little bit of forgetfulness, when a person comes up to you, they know your name, but you don't know theirs, awkward. That's normal. That happens. You go, oh gosh, that word, I cannot think of what it is, and then a few hours later you go, oh, that was it. That happens. For some people, however, they will experience more and more of those bigger issues. And that's what could be considered mild cognitive impairment, or MCI. MCI is not severe enough to interfere with daily life. We talked about that at the beginning. It's not every single day really profound, but it's also not normal aging. It's kind of in between. I bring up MCI for two key reasons. The first is, if somebody is diagnosed with MCI, they are now at an increased risk for going on to develop dementia. On the other big point, most cases, or at least many cases, of mild cognitive impairment are reversible. Lots of things can cause our brain to be a little bit fuzzy and not act normal. Lots of things can do that. Maybe you haven't been sleeping well. Maybe you're really extra stressed. Maybe you've been sick. Maybe you're getting over surgery or chemo. Maybe you're dehydrated. Maybe you've got a vitamin deficiency. Maybe there's mental health issues. There's all kinds of things that can cause some brain fog. Those sorts of things are reversible. There's another reason why you get stuff checked out really early on, because best case scenario, you fix whatever it is, you treat whatever it is, and the brain function improves. That's good. Now, for some people, their cause of MCI will not be one of those external factors. It will be because they are starting to develop Alzheimer's or dementia. Still, getting it checked out early on gives more treatment options, and it gives us more opportunity to figure out what to do, how to slow the disease down, how to adjust some lifestyle factors. We'll talk about those in just a second. But MCI is in between, but it is treatable in some cases. Yeah?
Do you want questions at the end, or does it matter?
Yeah, we're a small enough group.
I was just wondering, so if MCI is caused by external factors that aren't addressed, does that eventually, does it continue to get worse until then it does develop Alzheimer's? They develop Alzheimer's?
In some cases, yes. So things that are affecting the brain, that are really making it struggle, if they are not addressed, it does put a strain on the brain. And that does increase a person's risk for going on to develop dementia down the road. MCI, just in general, will increase risk, but if you treat it, that really helps. So, good question. All right, quick recap. We've covered a lot here. So, know Alzheimer's is the most common form of dementia, but it's not the only form of dementia. It starts in the memory center, but it doesn't stay there. It affects the whole brain. As we learned from Dr. Alzheimer's patient, it is not just a disease of the old. There can be younger onset. In this case, we classify that as anything under the age of 65. So yes, all the way down to the 40s, really rare cases in the 30s, but those are kind of special. We also learned that the brain is complex. No two people will go through this disease in the exact same way, in the same pathway, the same symptoms at the same time. The brain is very complex. And this is a disease that affects the brain. So, big overarching theme here, Alzheimer's disease is not a normal part of aging. So, that would beg the question, if it's a disease, how do I get it? I know what I just said, but let me explain here. The number one risk factor that we know of for Alzheimer's is age. I will qualify this. So, the older a person gets, the higher their risk will get for developing Alzheimer's. But it is not a guarantee. It's not a matter of if you live long enough, you're going to get this disease. Public health, we like to deal a lot with risk, and I know that can be frustrating because people want to know, yes or no, am I going to get it? And we can't really tell you that. But what we can say is that after age 65, every 5 years after that, a person's risk for getting Alzheimer's doubles. You go another 5 years, that doubles. You go another 5 years, that doubles. So you're looking at 1 in 3 older adults over the age of 80 will have some touch of dementia. But again, not a guarantee. Not 100% when you reach a certain age. Another big risk factor, family history, our DNA. What genes do we get from the different sides of our family? Now, there's no one specific gene that if you have it, you're going to get dementia. Not how it works. But what we can say is that the more close relatives a person has, who they have Alzheimer's, the higher that person's risk is going to be. I'm not talking third cousin twice removed and she was 95. This would be brothers and sisters, parents, aunts and uncles, close to that person. If they got it, that person is going to be at higher risk for getting it themselves. But again, not a guarantee. You can also get people with no family history. And there can be sporadic cases that just pop up. We just can't predict. Now, regardless of how much we want to, we cannot change our age or our family. But there are some things that we can change. And that's where a big bulk of research has been looking, a whole subset in the last few years, at what can we do to lower our risk. And now we actually have tangible data that just keeps reinforcing itself, showing that lifestyle makes a difference. There are some who believe that lifestyle modifications can actually decrease risk for Alzheimer's by 45%. That is not a trivial number. In some cases, that might be the difference in risk between somebody who has a big family history and somebody without a family history. If you could lower back to the level of somebody that doesn't have it in their family, that's huge. Another one that pops up sometimes, and we'll get this on the next slide, is formal education. Now, what I don't mean is, did you go to Harvard or Yale? Is it a master's? Is it a bachelor's? What I mean by this is keeping your brain learning. That is a powerful thing. The more learning that you have over the course of your life, the lower your risk is for getting dementia. Doesn't matter how high of schooling you got, but if you are learning, that helps. Sometimes, though, there are groups that are affected almost regardless of some of these other factors. For instance, of everybody living with Alzheimer's right now in the world, 2/3 are women. It is not a 50-50 split. 2/3 are women, and we don't totally know why that is. Lots of really interesting theories. And even when you take into account the fact that women do tend to live longer than men, when you control for that statistically, there's still a difference. At birth, there is a difference. And and we're not quite sure why yet. Also, some races have different levels of risk than others. The African American community, they are twice as likely to develop dementia as Caucasians are. For Latinos, that's 1.5 times more likely. If we could understand some of that, that would go a long way in helping us to understand about the disease in general. But what we have learned is that the list of risk factors that we can control has changed over the years and has really come into focus in the last few. The reason why I say that is because this list looked very different when I first started doing programs like this almost 10 years ago. Some of these things were separated out, and now we're kind of understanding that they group together under similar categories. There's a reason why those activities actually help. The biggest of which deals with heart health and specifically blood pressure. Lots of data in the last few years that keep pinpointing in on blood pressure dramatically affects risk for dementia. The closer a person can get that top number down to 120, the lower their risk is going to be. If a person has high blood pressure at some point in their lives, their risk is going to go up. But if they treat that high blood pressure, the risk will start coming back down. Several things that used to be on this list that were separated out, what did they actually do for the body? They helped lower blood pressure. It makes sense now. Even things like diet and exercise, which are worthy enough to get their own call out up here, they affect blood pressure. Some of the things that we talk about for diet, we literally talk about the Mediterranean diet and the DASH diet. The DASH diet is for high blood pressure. And data kept coming back and saying those two diets really lower risk for getting dementia. I mentioned formal education. Now this is slightly different than cognitive and social engagement. I like to separate those two out. Learning is great, but keeping your brain active is also really helpful. What I mean by cognitive engagement is pushing your brain out of its comfort zone. It doesn't have to be learning new stuff, but it can be. But if it makes you think, if it's challenging to you, that's good for your brain. And research keeps coming back to the fact that if you can do some of these things, or really anything, socially, with other people, that further lowers your risk. People who are social, they feel more connected, they feel more supported. Research has found they have fewer chronic conditions, fewer emergency room visits, they tend to live longer, and they have lower rates of dementia. One that's come up the list fairly recently, this is pertinent in my family, is untreated hearing loss. What they found is that people who had a hearing loss at some point in their lives, their risk for getting dementia goes up. But treating that hearing loss at some point down the road actually begins to bring the risk back down. If you think about the reason why that is, there are parts of our brain that specialize in each of our senses. Sight, sound, hearing, touch, taste, all that. So there are parts of the brain that deal with hearing. And if there's a hearing loss, that part is waiting for signals to come in. Maybe it's not getting any, or maybe it's getting a lot fewer than it used to. And after a while, that actually affects that part of the brain. A couple of things could happen there. The brain can actually reassign those brain cells to go do something else. Or those brain cells just don't work. They're not needed, so the brain prunes them back. Lots of theories on why that increases risk for dementia, but it does. So treating that hearing loss, cochlear implants, hearing aids, those sorts of things, begin to get those signals back. It begins to get the brain to retrain those centers, and you're healthier for it. A couple of other things that have come on the list that we're still investigating, new data on these. One of them is on sleep. Now, we've known for a long time, sleep is tied to memory. That's not new. We know that getting better sleep, getting proper sleep cycles, dreaming, that is good for consolidation of memory, cleaning up waste in the brain. It has benefits. People feel better. But new research has looked specifically at people who have trouble sleeping at night, and specifically take sleep aids. Research has found that people who take sleep aids regularly, they are at a fairly high risk for dementia compared to somebody who sleeps naturally. Now specifically what I mean by that would be things like Benadryl or the PM medicines, anticholinergics. The reason why that is because when you say anticholinergic, the choline, the acetylcholine that is in the brain is actually used for memory formation. It's part of a healthy brain. Suppressing that, yes, it can help with sleep, but first off, it's not really quality sleep, and two, it affects memory. So long-term use can actually drive down cognitive performance on memory, and you begin to get less quality sleep. Lots of really interesting research on that, but the good thing is there are a lot of natural sleep aids where that risk does not change. So things like melatonin, which the data on that is not super concrete, that absolutely taken in this amount and you're guaranteed to sleep, no. But for some people, melatonin does help. There's also non-anticholinergic medications that can help with sleep too. Check with your doctor. If you are fitting that bill, see if there's something else that they can prescribe. Lots of alternatives far beyond just a simple listing. The second bullet here gets at the idea that the lungs are actually also very important in the connection to the brain. We talk about heart health. If you want a simple message from that, what is good for the heart is going to be good for the brain. Simple. But now we can actually say lungs might be included in that too. It's not as rolling off the tongue to say what's good for your cardiovascular system is good for your brain, but the idea is the same there. Specifically what they've been looking at recently is one thing about air pollution. I'm not talking about like factory stuff, but there's data that was fairly recent that looked at a specific size of particle in the air, particulate matter 3.5 it was. And they found that people who had long-term exposure to that had an increased risk of dementia. Now why do I bring that up? This type of particle doesn't come from factories or cars, it actually comes from wildfire smoke. Now certainly we've had a lot of that here in Iowa in the last couple of years. Early days on that data, so keep an eye on that. We think there's a correlation, don't know the causation yet, not really sure. But what they found is that people exposed to that, at least at some degree, are at a higher risk for dementia. Stay tuned on that one. The other side of the lungs deals with smoking. Now, smoking being not great for your health or your brain, that's also not new. But what really blew me away with some fairly recent research is that what they found is that people who smoked and then stopped smoking, within 4 to 7 years, their risk, which was elevated from smoking, came back down to the level of somebody who never smoked. That blew my mind. I was not expecting that. I thought once the damage is done, it's done. But no, the research says it actually improves several different aspects of brain health and oxygenation and everything else that the lungs naturally do. So there's a lot that's out there. Several things that I could put up here that haven't. For instance, the GLP-1 medicines, the Ozempic, Wegovy, the weight loss drugs that are really popular nowadays. Early research, not a lot has been done on those, but early research found they actually decrease risk for dementia. We don't totally know why. Perhaps it's because it helps with the blood pressure side of things. We don't know. Could be several different things. So stay tuned on those bottom couple of bullets. But those are risk factors that we can control. Some of those are more involved than others. But I mentioned the cognitive side of it. That's something any of us can do at any stage of life and wherever we are. It gets at this idea of a cognitive reserve. I don't know if anybody's heard of that term. Fascinating stuff. It actually goes back to, in part, a study in nuns in a convent. The thinking back then was, maybe these nuns are actually checking off some of these boxes that we tell people to do. You know, stay active, stay social, you know, don't eat big extravagant meals, keep your brain active. So they followed these nuns for a while to see how did they do? How did they age? Now after several of them passed away, the researchers thought, okay, let's see how healthy their brains are. Maybe they've been doing something right. And when they looked at some of their brains, they looked like they had Alzheimer's. They had no symptoms. This kind of flipped what they were expecting. That surprised them, but it introduced this idea of perhaps all of that stuff that they were doing was building a more resilient brain. It was building up this extra reserve that as the disease is trying to pull you down, you've got extra to pad before the symptoms start to show up. Now, since then, there's been all kinds of research into this, and it just keeps reaffirming. If you can make your brain more resilient ahead of time, it's going to take a lot more for that disease to pull you down. There isn't a one-size-fits-all with this. It can look like a lot of different things, but the point that I got at earlier is if you challenge your brain, push it out of its comfort zone, do something that isn't second nature to you, it's just like building a muscle. You know, picking up the lightest barbell is not going to do much for you, but picking up one that's a little bit heavier than what you think you can do, that helps. Same idea here. Go beyond the easy. Push yourself, and it's going to make a difference. Since we're in a library, maybe it's reading. You love reading. Switch to a different author, a different writing style. Maybe go from fiction to nonfiction. If there's something that you've always wanted to learn about but you've never taken the time to, dive into it. If it's something that you think, it's a little bit more advanced than what I think I can handle, I don't know if I'm ready for that, try it. That's going to benefit your brain. And if you can do things socially through some of this stuff, even better. So we talk about formal education, we talk about learning, things like, library presentations where you're learning about interesting subjects. Brownie points, that's good. You're doing a few different parts there. All right, so we'll kind of scale back a little bit from some of that hopeful positivity and control and say, why are we talking about this? How widespread, how big of an issue is this? All right, we thought we would dampen some of that by instead doing some audience engagement. We thought this would be a great idea to raise spirits. All right, true or false? Alzheimer's is one of the top 10 leading causes of death in the U.S. Give you a second on that. Anybody for true? Okay, now we're getting a couple nods. Anybody for false? We're a small enough group, you can abstain, but I will know. All right, we're kind of split on that one. As of the most recent year, the answer is true. Let me explain on this because I was a little surprised at this as well. Alzheimer's right now is the 6th leading cause of death here in the U.S. It is what we consider to be universally fatal, which means that one way or another, if a person gets this disease, they're going to have it for the rest of their life. It can be a direct cause of death, like we talked earlier, where the parts of the brain that keep us alive, if they are destroyed, but it can also be a contributing cause of death. Lots of things can happen to somebody living with that disease that can be very bad for them. It's not always as simple as that getting classified as such, so you'll hear a lot of people who had that as a contributing factor, but it never made it onto the certificates. But it is out there, and it's very common. The total U.S. population of people living with Alzheimer's is around 7 million right now. There is a new case every 65 seconds. Think about the time that we've been here, 65 seconds. When I first started, about 10 years ago, that number was around 70 seconds. So it's picked up the speed as the U.S. has gotten older in its population. And they expect that trend to continue to almost double by the time we hit 2060. That's if we don't have anything between now and then that can slow down or stop the disease. And we hope that we will have something by then. But you can imagine there's some really extreme costs that go along with escalating numbers like that. And it changes population distributions. This is kind of a cumbersome way of saying it, but if you are 70 years old and you have Alzheimer's, you are much less likely to make it to age 80 than somebody who is 70 and does not have Alzheimer's. It impacts the public health system. Here in Iowa, we see some kind of interesting numbers as well. I wondered how we would do because we are an older state. And there's different estimates for the total number of people affected. Right now, one of the main estimates says there's around 62,000 Iowans who have this disease, but they have, between them all, over 100,000 caregivers. So now this begins to get a lot more prevalent than just the people diagnosed. Iowa is an older state. We are 6th in the nation for percent of our population over the age of 85. And I think don't quote me on this, I think we're 2nd in the nation for percent over 85 who are still working. We are an older state. So I wondered at the beginning of our program's existence, first off, how are we doing numbers-wise here in Iowa with direct resources. So we contracted with the University of Iowa, and they put together a landscape assessment. What they found is that of all the primary care physicians, PCPs, primary care physicians in the state, only 38% of them are located in rural areas. Not ideal. Iowa also has only 6 memory care clinics. These are specific hospitals that have a designated part of them that specializes in diagnosing Alzheimer's and dementia. 6. That is the lowest of all of our neighboring states. Wisconsin, as of a year or two ago, they had 40. We have 6. Not great. So then I wondered, how are we doing just for sheer numbers of doctors? And what I learned is that for every family care doctor that's out there, for every one family care doctor, there are 1,200 Iowans. Now, obviously, not every doctor sees 1,200 people, but math with me here. So then I said, okay, let's go from family doctors down to neurologists, people that specialize in the brain. Well, there's fewer neurologists, so that means a bigger ratio. For every one neurologist, now there are 5,000 Iowans. And if we go a step deeper into older adult specialists, geriatricians, that number almost triples. 15,500 Iowans for every one geriatrician that we have. We don't have a lot of them. That is and was and still is disconcerting. It's not a quick, easy fix. Thankfully, there have been a lot of things that we are working on behind the scenes to try to change that. We're working directly with some of these schools, some of the training schools, medical schools, to try to tell people, hey, this is a viable career option. There is a big need all over the place. CNAs, physician's assistants, doctors, geriatricians specifically, people who want to work with older adults, direct care workers, community health workers. So we've been trying to work with them to increase training. We're trying to increase training for the people who are already in these roles. And we're also trying to beef up resources to connect people and doctors. Because a lot of times doctors are a little reticent to diagnose this because they don't know what resources are out there. So we can talk about that a little bit later. I'm going to get ahead of myself there. All right, let's liven the mood again. More audience engagement. This time it's multiple choice though. What percentage of Alzheimer's care in the U.S. is provided by unpaid caregivers? We just talked about doctors and physicians and all that, but what about unpaid caregivers? Is it 23%, 43, 63, or 83? Anybody for A on the low end? Ooh, no optimists there. Anybody for 43? B? Tempting. C, 63. A couple takers, and then pessimists, D, 83. Got a couple of those. Unfortunately, the pessimists are also realists because it's 83%. 83% of care overall is given by unpaid caregivers. I wondered when I first saw that number, how could that be? The reason why is a very common misconception that people have. And that's this idea of where are these people? They're not in care facilities. They're not in specialty units. 70% of people with Alzheimer's still live in the community. They live and they work with all of us. They use the same services that we do. They navigate the same stores and the same transportation. And I'll have people that say, I don't see people with Alzheimer's. That's surprising. I think, what do you mean you don't see? What do they look like? I mean, there's no, they don't turn into something when they get Alzheimer's. They look like normal people. So that's where this whole idea of dementia-friendly Iowa, dementia-friendly communities comes from. If they are in our community, how can we make sure that things are a little bit easier for them? Are our signs clear and easy to read? Are the sidewalks in good order? Are businesses who are exchanging money at the cash register, are they trained to know if somebody is struggling, if they're writing the same check a couple times or they're having trouble with something, do they know how to step in and help? Those are things that we and some of our partners have been working on because they're out there. A high percentage live in their home, some with a spouse. 25%, I think it was, actually live alone. They're out there. Those 7 million who have the disease have 12 million caregivers, and look at the amount of care they provide. They don't get paid a dime for it. So who are those caregivers? Well, just like people living with the disease, 2/3 of all caregivers tend to be women. Many of them are in this sandwich generation where they're taking care of their own children, and now they're having to take care of their own parents as well. Quite a few are still working, and over half of those caregivers have been doing it at least 4 years. You can imagine the kind of toll this takes, especially in a progressive disease that runs long-term in some cases. And the numbers reflect that. Caregiving is hard on every front. Physical, social, psychological, emotional, economic. All of these things get affected when you're caregiving. Here in Iowa, we found 62% of Iowa caregivers say, yeah, I've got extra health things going on in me that I didn't have before I was a caregiver. And a lot of them say, I can't go get it checked out because I'm too busy caregiving. This really ratchets up emotional stress, there's mental health issues, there's also an impact in the workforce where at some point for a lot of people, they cannot continue to do both. And nearly every time in that case, caregiving is going to win over the job. It's tough. So knowing this, at the beginning of our program, I wanted to try to figure out what resources currently exist for the people with the disease and for the caregivers. There's got to be stuff out there. And what I found is that there is, but they're not always working together. They, in some cases, don't even know that the others exist. So now we've gotten them talking to each other. We've gotten them on our coalition, and they are working together. They're doing stuff. One of them that popped up early on were the Area Agencies on Aging, AAAs. There are 6 of them around the state, and each one specializes in a certain set of counties. And they are kind of like the local experts knowing what those counties have in them. But unfortunately, the Area Agencies on Aging only see about 3% of Iowa's population in a given year. Very underutilized. We also learned that the Alzheimer's Association is doing stuff. Now, obviously I knew that because I worked for them before this. And a lot of people know about them for their fundraising walks and some of the other stuff. But there were a few resources that I think really needed called out that anybody could use. One of those is the Community Resource Finder. It is a website where you can put in your zip code, and it will show you by distance what is closest to you for a variety of things. Home health aides, diagnostic clinics, support groups, AARP programs, respite care, you name it. They've got a lot of good stuff on there. Some things are also offered virtually or over the phone. I think perhaps an even better resource. The Alzheimer's Association runs a free 24/7 helpline. Back when I used to do a radio show over in Fort Dodge, I actually had the head of that call center on my show because I wondered what goes into it. They're based out of Chicago. They train everybody there. They are all master's level clinicians and above, and they are good at what they do. They take thousands upon thousands upon thousands of calls every single year. They've heard it all. So you can call them if it's 3 in the morning and you say, hey, my loved one, they don't recognize me. What do I do? They can help. If you call them and say, it's about time for Dad to stop driving, how the heck do I have that conversation with him? He's not going to go for that. They can role play and figure out what's a good game plan for you. You can call them and say, hey, it runs in my family. I don't want to get it. What can I do to lower my risk? And they can walk you through some of the stuff that we talked about today and more. I'll put up that number at the end, but really use them free, 24/7. They also keep really good notes. So if you're one of those people that always gets annoyed that you have to explain yourself every single time, like me, then they really try to avoid that. There's also something called Alz Navigator, which is more for the logistical type person. Okay, if you've got a diagnosis or if you're at this point in the disease, Alz Navigator can walk you through what are some of the next steps that you need to take. What are the big things that need to be hit on in what order? And they can help with that care plan going forward. Something that we heard of from the doctors that we talked to was the annual Medicare wellness visit. This is something that anybody on Medicare can go in once a year for free and get a checkup. It's not like a physical checkup, it's more like a wellness checkup. So they look at lifestyle, chronic conditions, they do some scans and some tests to see how are you doing overall and come up with a plan going forward. However, we learned that only about 25% of Iowans on Medicare ever use it. They just don't go in. Now, why this is pertinent for our program is because, by definition, the wellness visit should include a cognitive screening. Unfortunately, not all doctors do it at this point. This cognitive screening is known as the mini-cog. It's a really short, almost silly test. Seems oddly easy. Maybe you've heard of some of the things like they ask you to draw the hands on a clock or remember some words and then they're going to ask you later. You think, well, 5-minute test, what's that going to do? I can tell you statistically, that test is good at detecting subtle memory changes. It'll show up on the test. So just keep that in mind. But people will also say, my memory's fine. Why should I go in and get that? Because most people who get diagnosed later, who maybe fail that test later, they have never taken it before and they don't have a baseline. They can't say, 5 years ago I aced this thing. I've been great at it for the last 10 years. I go in every single year and I always score perfect. Why didn't I this time? A lot of people don't have that. So you might get a score, but you have nothing to compare it to if you don't go in and get it checked every once in a while. Now, not all doctors do it in that order. Not all doctors do the mini-cog at all. I've literally had some doctors say, I just normally ask them, hey, how's your memory been? That doesn't work in this disease. It's a memory disease. You can't do that. So we're trying to change things. We actually have a statewide summit that's coming up next month. We've invited doctors and hospitals and healthcare systems from all around the state. We're going to be gathering in Des Moines. Dr. Shaw from Broadlawns, Yogi Shaw, he runs their memory clinic down there. He's going to be presenting. Mayo Clinic's going to be presenting. We're going to hear from insurers and other doctors and all kinds of people. We're going to teach them the mini-cog. We're going to stress the importance of early detection, case management, all this stuff. We are trying to change how things tend to go because I have heard a whole gamut for people's experiences with wellness visits. From great, they do everything to a T, to I was in and out in 5 minutes and I got nothing from it. We don't want that. We want to make sure that they're actually doing what needs to be done. And it's going to be helpful. There's also a few different things out there that are great for the caregiver and for the person living with the disease. Support groups, really important. There are support groups all around the state, but they are still too few and far between. So we've worked with some of our partners, like Dementia Friendly Iowa, the Alzheimer's Association. They can help. If there's a person that says, I want a support group, but nothing exists around me, they will provide the resources and the training to get support groups started. They will help you sustain that. Wherever you are, they can help. They've also diversified. It's not just support groups for the caregiver. They now have some that are for people in the early stage of the disease. So they both go. Caregivers go to one side, people with the disease go to the other. They started a young adult caregiver support group. The demographics have changed a bit. More young people are having to be called in to be caregivers now. They also have some in multiple languages, so we're trying to get more out there. Some are still over the phone, some are virtual, a lot of them are in person. We want to spread that.
We are fortunate to have a support group here.
I did see that, yes. Yep, thankfully that is true. Not everywhere I go, in fact most places, the really, really small towns that I go, like this morning, they do not. So you're very lucky. Yeah. On the other hand, this is also a really crucial one. Respite care is huge. It makes a huge difference for people, but they are so rare. We just don't have many of them here in Iowa. The idea behind respite care, if you're not familiar, is you can take your loved one and leave them there for part of a day, for a whole day. Some rare cases, multiple days, but not around here. And that caregiver can go and do whatever they need to do. They can go get groceries, take care of the house, they can go to their own medical appointments. And that person who is at that respite care facility, they're engaged, they're with others, they're being taken care of. They can do stuff, it gets them out of the house. Everybody that I talk to, most people at least, they say, man, that's a really good idea. Where do we have one of those? And I have to go, ugh. There's not one around here. Now, some places they do have them, but we're trying to figure out, hey, why is that? Why is there such a need, but almost no supply? It's a really complex issue. We've been working on it for quite a while. What we have done, what we've noticed at least, is that after COVID, the most successful respite care was formed by community members, volunteers. The community adult day model has been more successful lately in some communities than the medical one. So we've gathered all of those together. We've got them talking now. We're trying to figure out how can we help make that replicable to other places. I've been working with the National Association for Adult Day, and we're trying to get a guide together, a step-by-step guide of how do you start one of these here in Iowa. Hopefully that'll be coming out in the near future. going to see that we have, in the last couple of slides, started to connect the dots a little bit. That's why we exist. Our whole funding tells us we need to build up dementia infrastructure in our states. So by getting all these places together, by improving access to resources, that's one step. But on the other side of it, there are some really big breakthroughs happening well beyond us. For the first time ever, we now have medications that can slow down this disease. We've never had that before. We've had medicines for Alzheimer's, but they only treated the symptoms. Those brain changes that we saw illustrated, still happening, but the symptoms were treated. Not so for these. At the beginning, I talked about amyloid and tau and said, oh, great, all right, let's just get those out of there then, right? That's actually what these medicines do. They teach your immune system to go, that big ugly plaque, that should not be here. So I'm going to go in and treat it like it's an infection. I'm going to treat it like it's a bacteria, and I'm going to remove it. And what they found is that these medications can actually slow down the progression by up to 30%. Now, it's not as high as, obviously, we would all like, but we went from zero, nothing for decades, and now we're at least 30%. Data's still coming in on both of these. These are infusion medications. This one goes by the brand name Leqembi, and this one goes by Kisunla. They are fairly new, within the last year or year and a half, a little bit more than that for Leqembi. But now there are, I want to say, more than 24 Iowans who have started to get these infusions in different parts of the state. Still few and far between, but more hospitals are picking it up. More are able to give this infusion. Leqembi's a twice a month, donanemab's a once a month, I believe. They're getting there. We're starting to see them more and more. On the other side of that, we have now had an FDA-approved test for Alzheimer's. A blood biomarker test. So what do I mean by biomarker? Biomarker is kind of like blood sugar and diabetes. It's something you can test to see how are things going in there. So in this case, it looks for specific proteins that are circulating in the blood and ratios of those proteins to each other to figure out with pretty high certainty whether a person is developing Alzheimer's or not. The clinical guidelines for this were just released. These are not yet diagnostic, but they are getting a lot more accurate, above 75, 85% is what they're shooting for. In order to be diagnostic, they want to get them above 95%, and we are trending in that direction. But somebody can now go into more hospitals than the infusions, at least, and get a biomarker test to see, could you be developing this disease? That feeds into this next one, which is the US Pointer study. This is a very long-term study. Lots of data. It looks specifically at lifestyle. So, all right, if you have a positive biomarker test, maybe you want to start doing some of those lifestyle changes. Big data set just dropped back in July that found that people who do those lifestyle changes well, you can actually slow down the progression of Alzheimer's by 2 years. That really surprised a lot of people at the research conference when that came out. Again, highlighting the importance of detecting stuff early on. But there are things that we can do that are now giving us more power than we've ever had against this disease. And if we couple that with being willing to talk about it and being willing to drive down that stigma, treat these people as normal people who are going through a disease, it's going to make a big difference. That's kind of where we come in. So before you leave, feel free to come up here and check some of this out. I've talked about some of our partnerships. Three big things that I want to highlight. We worked with Dementia Friendly Iowa, which is based out of the Northeast Iowa Area Agency on Aging, to come up with a dementia resource guide. They had already created something similar to this, for the most part of this exactly, but we added some of our resources, some of our old coalition resources, and we packaged this into a short little document that is dense. Really good, in my opinion, resources to point people in the right direction. Our program also created a one-pager that explains the importance of the wellness visit. Reminds you to go get it, reminds you that maybe there are some things you might have to prod your doctor on a little bit, but they should be doing this stuff. And then finally, I mentioned our coalition earlier. The reason why we gathered that coalition is because Iowa did not have an active state plan to address dementia. Now we do. We published this about 1.5 years ago, so we're coming up almost 2 years now, We're coming up on the update of this. But it's 60-some experts from all around the state and all different connections to the disease, and they put that together with digestible, easy-to-read recommendations for anybody. So please check that out. One last thing. As I've gone out and done a lot of these in different libraries around the state, I've seen the importance that libraries play for being a trusted local resource, and how in some cases that might be the only resource in a really, really small town. Even in the middle-sized towns, even in the bigger towns, it can operate in this very unique space. So I thought, what are some ways that we can equip libraries better to serve those who have dementia or their caregivers? And one of the ways that we came up with is a memory kit. Not many of you have heard of this concept, but this is something that is full of activities that a caregiver can do with their loved one. Again, it gets at that stigma of, what do I do with them? Now they've got dementia, how do I interact with them? What do we do together? This answers that. You could buy a lot of kits online. I didn't like the look of them. They're not very robust. They don't really deal with all of the senses. So I designed this kit myself to appeal to any stage of the disease, multiple senses. It's got information in there about the disease. It's got caregiver support. There's a children's book for how to explain this disease to children. It's written by an Iowa author. And there's also some DVDs that were made by an Iowan as well to get his dad to see the family farm on Main Street. He stuck a GoPro on his car and just drove around. Something familiar for him. So I'm going to leave this here at the library. This is for you. Please spread the word on this. A lot of people don't know what memory kits are. I want this hopefully to be around for a little while because this is going to be multifaceted for people. Try things. What works one day may not work the next. This kit has other things for people to try. So please make sure people know those exist. Last thing is I'll pass out a survey here. You don't have to fill it out. You don't have to put your name on it or contact information or anything like that, but it just helps us to tell how we're doing. All right, so while that's going around, I'm going to put up my contact information, some of the resources that I mentioned, the Resource Finder, the Northeast Iowa Area Agency on Aging, and then that free helpline also down there. If nothing else, feel free to take a picture of this. It's easier than writing it down. But I'll just say, thank you so much for having me. I really appreciate you being willing to hear about this, and hopefully I've convinced you by the end of this, go out and tell others, hey, I went to this. Hey, I learned something. This is really cool. Hey, I just learned that we have this now coming down the pipeline. Those sorts of things are going to help. So thank you for having me.